added a few pictures from last time. There were some that got deleted, so I thought we would just start here. We talked last time about infection with viruses such as adenovirus and acute hemorrhagic conjunctivitis. And then we moved on to herpes simplex. And I thought I'll show you some examples. This is a primary herpes simplex, as we talked about last week. Usually occurs somewhere between sometime in infancy or early adulthood, and this is the typical presentation of a blepharodermatitis. And in this case, this child's a little bit older, so this could even be a recurrent lesion. It doesn't necessarily have to be the primary. Usually the primary, the children are sick and they've got a high fever, and often it gets passed off as roseola or one of the other viral enanthems of childhood. And this is just a typical follicular reaction with sort of the gelatinous lumps that you see here. There's some, looks a little papillary as well, but by and large, the reaction I think there's is those little globules that we see with the follicular reaction. And then the virus goes into dormancy in the neural tissues, and it travels antegrade to the eye, and various situations can cause the virus to erupt. And it tends to erupt in the area where the initial infection entered the body. So if the person's unlucky enough to have a blepharodermatitis, then there's a good chance that it will probably recur in the same region because the virus has gone to the trigeminal ganglion. And we typically think of the recurrence as being either a dermatitis on the skin or an epithelial keratitis with a very, very classic pattern. And it's mainly a clinical diagnosis. You don't have to do a viral swab to know that it's herpes, although sometimes in certain situations, if you're uncertain of the diagnosis, you may want to do a swab and send it for PCR to either confirm the diagnosis or I suppose it's hard to get sensitivities with the virus, but occasionally we end up with a funny looking dendrite that's been going on for a long period of time, and or we've got a patient that just confuses us for months and months and sometimes even years, and then we get the idea to do a swab and actually pick up the virus. So let's just look at some clinical examples. This is the dendritic pattern with retroillumination. You can see that there's a bit of interstitial keratitis here with the blood vessels growing in. But if you look with retro, you can see the very typical pattern of dendritic keratitis. And I put this one in because it's so pretty. And it's just very classic. It shows us the classic picture of the dendritiform lesion. The other thing that you'll notice is that it's got a diffuse conjunctivitis, really. And you can see the rose bengal stain picked up by the conjunctiva and by the devitalized cells that are at the edge of the dendritiform lesion. And here's another serpentine. Dendrite, I think, is the same. I'm not sure which one's Greek and which one's Latin, but I think dendrite and serpentine more or less mean the same thing. And you can see the perfect pattern. With fluorescein, the cells along the edge are devitalized, so the attachment to the basement membrane is interfered with, and so you get this fuzz of fluorescein around the dendrite. And so if you want to get a really sharp picture with fluorescein, you've got to you know, don't put the fluorescein in and then send them down to photography, because by the time that happens, it'll be spread all over the cornea. So if you want to get a nice, concise looking dendrite, you got to just put it in right away. This is probably an earlier dendrite. It hasn't quite developed to the extent of the other ones that we've seen. And sometimes it can be very subtle. With this one, looks just like a little barbell on the cornea. And once again, demonstrating the fluorescein spread. Rose Bengal and fluorescein will stain the base of the ulcer, and the fluorescein tends to spread. This is a ghost dendrite, just in retroillumination. You can see the sort of end bulb appearance, and then, you know, you don't need to stain these in order to see them. The staining, of course, makes them obvious to us, but often you can, you know, this patient has had a herpes simplex in the past, and now there's a dendritiform lesion that is erupting on a recurrent episode. And, you know, the problem with herpes is not the initial infection or even the first recurrence. Usually, is if you get an epithelial dendrite and it heals, often the patient's left without scarring, and they end up with good vision. The problem with herpes, as well as herpes zoster, is the recurrence. And every time it recurs, you end up with a little bit more scarring, a little bit more damage to the cornea, and sometimes it then morphs into a more serious disorder like a stromal keratitis that leaves the patient with poor vision. Now, if you saw this, you'd say, well, maybe he's got a little episcleritis. There's a little hint of something there. Knowing what this picture shows, I think we looked at it last week. But just to emphasize that, don't give up if you see that the cornea is clear. There may be herpetic lesions that look pretty typical on the conjunctiva as well. Now, in terms of treatment for recurrent disease, we've had problems getting trifluorthymidine or Viroptic for the past couple of years. It's sometimes on back order. Tanya, you're going to say something?
I think your microphone might be rubbing against something.
Oh, yeah?
Yeah.
Oh, you know what? It's me. I'm playing with the keyboard.
Yeah. Sorry. I'm a
Sorry.
perfectionist
No,
for your
thank you.
videos.
I appreciate that. I'm a fidgeter. My wife gets on me all the time about fidgeting. But we did have some problems getting trifluorthymidine, which is Viroptic. It's a good drug for herpes simplex. It does have toxicity, but it's not so bad. If you came from the era where idoxuridine was used, or Vira A. Vira A wasn't as toxic, but idoxuridine was very toxic. It was called Stoxel, and I believe it's not available anymore. Just a little bit of ophthalmic history. My mentor, Herb Kaufman, when he was a resident, discovered the first antiviral that was useful in human viral disease, and that was idoxuridine. So he went on to become chairman in Gainesville right after his residency at the Mass Eye and Ear. So he's obviously an unusual individual. That it was great to have the chance to work with him for a couple of years. But he had he spent his career studying herpes afterwards, and he also was involved in development of Timoptic with what's the guy's name in Louisville? Tom Zimmerman.
Prof, I think there's still a rubbing sound coming
I
pretty
got to
good
sit
through
on
to
my
us.
hands.
I think
How
so.
about now? Is there now? Is it gone?
That's good.
Okay, or maybe I'll move Yeti up to the next level. So we'll see if
We
that.
need to give you a cornea to suture while you're giving the talks.
Yeah, exactly. Okay, that's a good idea. All right, so neuroptic might not be available, but we do have available Zovirax only by special access in Canada. I know in Australia and I think in Israel as well, Zovirax is available as a 3% ointment for eye use. So you can get the 5% ointment. That's easy enough to order, but and it's probably okay to put it in the eye, but it's not certified for that purpose. So if you've got a patient who's very sensitive to trifluorothiamidine, or if you can't get it, you can treat topically with Zovirax ointment. And in many cases, because of the lack of availability of topical antivirals, we're just putting them on systemic acyclovir, which is good probably not in 98% of cases. It's very, very rare that we come across a strain of herpes that's resistant to acyclovir. So you can put them on the typical dosage is 400 milligrams 5 times a day. So it's about half the dosage that we use for herpes zoster during the acute stage of zoster. And that is effective. You get good tear penetration, and the dendrites will typically heal up within a week or so. There are some dendrites that take longer to heal. I haven't seen a limbal dendrite in ages. They're supposed to be more common in people that are immunosuppressed or have had renal transplantation, and typically they're said to take longer to heal. But the usual course is that with treatment they'll heal within a week. There are some older methods of treating them. What people used to do was debride and use iodine, and that's before my time. But I have seen patients with sort of diffuse scarring with herpes, and I always wondered whether that was a result of the virus or was a result of the treatment with the iodine, which can be quite toxic to the cornea at least during an acute episode. Usually iodine, at least povidone iodine, is quite safe to the cornea as long as you don't overdo it or have too high a concentration. But the topical iodine was more damaging as far as I know.
You can get the same, like just to touch on your point, like with Zovirax, if you're using it more than 10 days, you can get an epitheliopathy with that. So if just for people who are not used to using it, and I know our Israeli colleagues are probably all over it, but if you're going to use it in Canada, then you do need to watch that surface and probably try and switch them over to something systemic after about a week or so.
Yeah, Adi, what is in Israel? Are you using Zovirax there for the ointment?
So sometimes we use the ointment, but sometimes you cannot get it. Like nowadays, you cannot find the ointment anymore. So we use systemic, but we use both, whatever there is available.
Right. They were both made by the same company, and Zovirax was launched in Great Britain and the colonies and in Europe, whereas Viroptic was introduced in the United States, and it costs a lot of money for them to go through the regulatory process. And so they had Viroptic, and most North Americans prefer the drops to the ointment. So I think that's the reason why we never got full approval for Zovirax in Canada and in the United States. So it's not that it has to do with medical politics and corporate issues. So here's
I've also seen sometimes some clinicians actually give out both at the same time, which never made much sense to me. I don't know of any evidence also supporting it, and I wonder what your thoughts are about that.
For using both?
Yeah, the oral and the topical at the same time. I've seen it done. I don't think it's justified. I don't know of any evidence justifying it, but I've seen it done.
If with just an epithelial dendrite, I don't think there's justification for both of them. The only, the head study, which looked at use of oral acyclovir, the only time they came up with anything that was close to significant was with uveitis and long-term use of or not long-term use, but short-term use of oral acyclovir. And the head study also showed that you can decrease the incidence of recurrence by keeping them on it, but most people don't want to take an antibiotic, even though it's very well tolerated, because acyclovir has to be activated by the viral thymidine kinase. And so it's not very toxic to mammalian cells. You can keep patients on it for months and years without any physical harm or even allergy or any side effects. So here's the differential diagnosis of a dendritic lesion. This is one that we talked about last week that it's important to have in your pocket so that you can impress your attending physician. But if you remember these 6 entities, I think I surprised Aya last week by talking. Who did I surprise last week about the type 2 tyrosinemia? That presents with a very typical looking herpetic dendrite, but of course it doesn't respond to antivirals. And if you have resistance, then we've had a couple patients where we've used ganciclovir topically, and that's often clinical judgment. If the patient's not getting better and you sort of throwing up your arms, not sure what else to do, sometimes switching them to ganciclovir will be helpful. And we'll just go through a few more pictures here. You can see pseudodendrite, and a little bit of dryness or SPK above. So this is in the dry eye zone or in the lag ophthalmos zone, so could very well be related to lid closure and epithelial healing. These are perilimbal microdendrites that, if you're lucky, it's not very often that we see them, but if you're lucky, you'll see microdendrites with herpes zoster keratitis. This patient, if I remember correctly, also had a 5th and a 7th nerve palsy, which is a very bad combination for the cornea. You can see you get this pseudodendritic pattern, although there's no epithelial defect, and you get vascularization as well. And if I'm not mistaken, this patient had neurofibromatosis. I looked after her for a number of years until she moved to a long-term care home up near Sudbury. But she had a 5th and a 7th. And here's another pseudodendrite. Could be from a healing epithelial defect. And this is that patient that I showed you before, just with retroillumination, showing the pseudodendritic lesion sort of stuck on plaque looking. And here's the perilimbal dendrites that supposedly, I remember this from Dr. Breslin teaching back from when I was a resident, saying that these perilimbal dendrites are more associated with immunosuppression, but I don't know if I've ever seen it in a textbook So I don't know if that's apocryphal or if it came out of one paper that was published, not quite sure. So if you add steroids, it's like adding barbecue lighter fluid to your fire, and you can end up with a very large ulcer. And here you can, and what we call that a geographic ulcer. And I remember one patient of mine that was referred in by a family doctor. The family doctor put her on cortisporin for a red eye, and cortisporin contains neosporin plus corticosteroid. And by the time she got to us, she had a very large geographic ulcer. And you can see here that it's losing its dendritic pattern, but here you can imagine a bridging dendrite between these two large areas of epithelial defects. And I like to tell the story of Mr. Ernst. Here's the geographic ulcer once again, who came in with the diagnosis of CMV keratitis, which is very, very uncommon. It's now been reported with a small sort of uveitic component, but in terms of creating surface disease, CMV is very, very uncommon. And Mr. Ernst, he had renal transplantation. He was on immunosuppression. He came in with count fingers vision in both eyes, had a dense white cataract in both eyes, had iris atrophy, and had a near total epithelial defect in both eyes. And the only thing that tipped us off that this was probably herpes is that we looked at the very edge of the ulcer right at the limbus, and it had sort of a serpentine pattern to it. And we cultured him, and he did in fact have herpes simplex, and eventually recovered 20/40, 20/30 vision. And he still comes to see us. He's had a couple transplants. He's had cataract removal. He's got glaucoma now, 9 yards.
So, boss, bringing up that important subject of the steroids in these cases, I see that you have the perfect slide in front of you for my question. What's your approach in cases when you have a graft on the eye and the patient's currently getting steroids for that?
Yeah,
graft?
well,
what's your approach then in such cases?
In a case like this,
because on one hand, you like a case with a dendrite, a big dendrite, and a patient with a graft. Because on one hand, you would have liked to maybe bring down the steroids, right? Because you want to try to avoid that geographic ulcer you just showed us. And on the other hand, you don't really want to stop the steroids, right? Because you don't want to increase the chances of graft rejection.
Yeah.
So I'm kind of wondering.
You go down to the minimum dose possible. You can go to 1 drop a day of either Maxidex, or you can switch them to FML while you put them on, oral acyclovir, and wait until the epithelium starts to heal or has healed up. That would be the classic teaching. So we're getting, this is I love this picture as well. I think it's so telling. The sutures are there. That's a well-healed graft, so we know that they've done. The graft was done quite a long time ago, and then the low-dose steroids has allowed a geographic ulcer to form. And I think this picture, it might have been before. Well, I think I'm pretty well been using acyclovir prophylactically in grafts for as long as I can remember. And there's a couple good studies. I think Stephen Foster from Boston wrote one of the studies where they looked at recurrence of herpes simplex after a graft, and found that it cut the rate of secondary infections or recurrent infections in just about in half, if my memory serves me correctly. And then, yeah, go ahead.
I was just noticing we have quite a lot of juniors on today, which is fantastic. Would you be able to just back up a slide just for the really junior ones and just maybe touch upon what makes an ulcer look geographic or neurotrophic for the beginner?
Well, it's geographic's different than neurotrophic, but just the sheer size of it. You know, the dendrite for the patients that are not on steroids has the beautiful dendritic pattern of very, very fine, like channel in the middle. You can see it going right down to basement membrane and stroma, surrounded, you know, with the typical flowery end bulbs that you get with herpes simplex. But when it's large like this, and we're talking for geographic ulcer, usually the intention is to say that the stroma underneath is relatively clear and compact. Once you start getting white cells infiltrating, you're moving on to then a stromal keratitis, you know, especially if there's loss of did you want to add anything, Tanya?
I think I worded my question poorly. I often get questions from my residents about how do you know if it's really looking at the edges of the ulcer. Sometimes my residents, if they've got a poorly healing epithelial defect and there is, you know, question of whether HSV is involved, I usually will get them to try and look at the edges of the ulcer and see if they've got that rolled edge, which sort of is less conducive that they're going to heal rapidly. So just looking, as well as looking at the stromal clarity as well.
Mm-hmm.
But it's just, it can be difficult to appreciate if someone doesn't point that out to you, that's all.
Yeah, and if you've got rose bengal, rose bengal should stain along the edge of it in a geographic ulcer, whereas if it's neurotrophic, you may not get that staining. Now, rose bengal, our pharmacy used to make it up for us. Now you get these little strips with rose bengal on it, and it's hard to get a really concentrated drop of rose bengal. You can use lissamine green, although I don't have that readily available. And it should give you a similar staining pattern, although it'll be green rather than red. But you can see here how the edges of it stain, showing that there's probably active virus there. And here's another post-graft recurrence with a huge geographic ulcer. And it's even hard to, but you can, if you look at the edges, you can imagine that there's been this dendrite there that's sort of spread out and become a geographic ulcer. And this is also a patient post-graft that developed ulceration on the cornea, but also lid vesicles. Now, if the patient's unlucky and the virus goes deeper, you can get a stromal keratitis, and there's, if you want to divide it up, if you like to divide things up, you can have a disciform keratitis, which is a type 3 immune reaction, and it consists of having localized edema. They'll have KP and a very mild AC reaction. So, you know, they're not going to have a hypopyon. If they have a hypopyon, it's probably going on to, it may be something else, and not a disciform keratitis. And these respond very well to steroid drops. And of course, you need to use an antiviral coverage at full dosage. And on occasion, it'll progress to a stromal necrosis or vascularization. And here's a photograph. It's a little bit contrasty, but you can see that if you look at the slit beam, it's thicker in the center and gets thinner towards the periphery, which is abnormal. And then this little spot here is probably a keratic precipitate. And here's a nicer picture showing once again, that if you look at the slit beam here compared to here or up here, so the slit beam is much wider, and there's this round central area. It's classically it's central, but you can have a peripheral disciform as well. So just because it doesn't observe the symmetry of the cornea doesn't mean it's not a disciform. And this is showing some white blood cells actually within the cornea. So it's not classically a disciform. It's maybe a disciform that's starting to progress onto more of a necrotic stromal keratitis. And the other differential diagnosis that is good to ingrain in your brains is the differential diagnosis of a ring infiltrate. And you can see here that there's sort of a ring of haze around the center. And it's probably due to, it's sort of like an immune reaction, like an octolony plate, where you get, where in the zone where the antigen and the antibody meet, you get a agglutination of and precipitation, so you get a ring. And so this can happen with herpes simplex. Here's a dendrite that is actually following the circular pattern of this ring infiltrate. You can also rarely get endotheliitis, and it's a form of disciform keratitis, but you may not necessarily get a central or a round disc of edema, but you may actually get like a rejection line without having had a PKP, and this can result in endothelial failure. And this is a patient actually that I saw when I was a fellow, and she had a history of herpes simplex keratitis, and she came in one time with a lesion on her chin, and as well this appearance to the cornea. And you treat them just like a disciform with steroids and antiviral, and you hope that they don't end up with endothelial failure.
Can I ask a question?
Sure.
How often do you see endothelial failure that needs to have DMEC or DSEC post disciform or iritis? Because I had few cases, like 3 cases on the last year, that looked just like a disciform keratitis or iritis, and they started to clear up once I gave them steroids, but then they start to deteriorate, and they ended up with endothelial failures, and there was nothing else. I mean, the other eye was perfectly okay, no guttate, nothing that could lead to fuchs or something like that.
Right.
And I was asking myself whether it was the right diagnosis.
Yeah, well, the only way, I mean, you could do an AC tap and to try and pin down the diagnosis. It's not very common, and at least not in my experience, but it definitely can happen. You can end up with endothelial failure that requires DMAC or
is it like treating graft failure? So the sooner you treat them, the better the outcome? Or not necessarily?
Well, chronic edema can lead to scarring of the cornea. So, you want to, it's always the controversy is when do you intervene with herpes? Most people will say wait 6 months with the eye quiet, and then you can go ahead with either a penetrating graft or, in a case of endothelial failure, with just DMEC.
And what I was asking is, if you treat them with, I mean, if it's a disciform keratitis and you treat them later rather than sooner, will it end up in being like more probable to go down the road to a demon?
Probably, yeah.
Because more endothelial cells are lost or something like that.
Yeah, I think so.
Okay.
So, Prof, we have an interesting question from the crowd. Do patients get reduced corneal sensation in non-epithelial disease such as stromal keratitis or endothelitis?
Yes, you know, the herpes viruses, the zoster and simplex, anyhow attack the nerves, and so you do get a hyposthetic cornea. So you know, any chronic ulcer will give you reduced sensation on the cornea as well, but we know typically that herpes simplex and herpes zoster give you, it's more frequent. Does that answer the question? Occasionally you can have iritis, and we talked earlier about the head study showing that there was a trend towards significance in the head study in using oral acyclovir in conjunction with steroids. Often the pressure is high, so you know, if you have a patient comes in with a hypertensive uveitis, it's very frequently herpes simplex or herpes zoster. And you treat with antiviral coverage to prevent any, to treat any epithelial disease that may occur while the patient is being given high dose topical steroids to treat their uveitis and their pressure. And here it's just, I'm not sure what this is trying to show us, if it's just showing resolving dendrite or if these are KP on the cornea. I don't have a good slit beam here, but you can see there's a little bit of scarring of the cornea. And here you can see the KP almost forming like a linear pattern on the endothelium. And sometimes we get a stromal keratitis. This is where you've got usually an infiltrate with an overlying epithelial defect. And this is probably an immune reaction to viral particles. You know, it was a controversy. I think it still is somewhat controversial as to where the latency of the virus resides. Is it in the cornea or is it in the neural tissue? I think most of us would agree that the place where the virus is it resides is in the trigeminal ganglia. But if you take the reason people thought that it was in the cornea is when people did a corneal transplant, you could culture virus from the cornea, or you could see it on electron microscopy. But it's probably the virus resides in the neural tissues, and it just becomes deposited in the cornea. And when it does so, if it creates an immune storm, sort of like the cytokine storm that people are getting with the COVID, you can end up with necrosis of the stroma and melting of the stroma. And the treatment for that is to start off with topical steroids, probably 3 or 4 times a day with the topical steroids, with antiviral coverage as well. There's always a risk that the patient's going to perforate and that they may end up with progressive melting. And sometimes it's hard to know whether it's just the natural course of the disease that they would have ended up that way. But if you don't treat the inflammatory process, they're likely going to get worse. And the epithelium is going to have a lot of difficulty healing over top of mushy cornea. So you have to do something. Now, some people will give oral steroids in in this case. And I think when I first started practice, I was pretty liberal with the oral steroids, but I had one patient with herpes simplex, an older man, and I gave him 50 milligrams of prednisone, and he became psychotic and he burned his house down. Luckily, no one was hurt, but his wife was left without a home. And I had another patient that with pemphigoid that I gave steroids to, and he ended up with sepsis, with pyelonephritis. And I had another patient who had a stroke, and at that point in time, I decided, you know what, oral steroids and old age don't mix terribly well. And one other story with regards to that is I went to buy a new computer at the Apple store. This is 10 years ago, and the guy saw my email address was University of Toronto. He said, what do you do? So I explained to him, and he said, oh, you know, my dad had a corneal transplant. And I said, oh, you're kidding. What was his name? And sure enough, it was this patient who I'd looked after. He'd had corneal transplants on both eyes for a treatment of alkali burn by somebody else in the city. And he was put on oral steroids, and he developed aseptic necrosis of the femoral heads. And so he came in with, with cane and walkers. He'd had hip replacements. And so with all of these issues with the systemic steroids, I've tried to stay away from systemic steroids as much as possible. And I think I'd rather take the risk that the patient may perforate rather than kill them with systemic steroids. And here's a typical stromal necrosis. You can see the eye is still fairly inflamed. It doesn't look like there's an epithelial defect. So it's been quieted down enough that the epithelium is healed. And here's another one, patient's pseudophakic. And this is another stromal keratitis with some necrosis. And in this patient with the stromal involvement, there's almost a dendritic pattern to it, but this is, you can see the chronicity of the disease by the presence of the blood vessels growing into the cornea. And I'm just showing you lots of examples. You can have a
How aggressive, Prof, how aggressive are you with managing vascularization?
Well, acutely, I think the management is to treat them with steroids. I don't think I'd give in the acute phase any anti-VEGF injections. Once the eye is quieted down, then I think giving either an intrastromal injection of anti-VEGF or even subconjunctival in the area where the blood vessels are can really help quiet things down. Years ago, I used to try and zap the blood vessels with the YAG laser, but first of all, it's a bit like chasing your tail, is that you zap one vessel and another one opens up. And the other thing is that you get them to the laser and you realize really how many blood vessels are there, and it's really hard to close them all off. Hermander Dua, he originated the technique where you take a monopolar cautery and you put a 10-0 nylon needle in the area where the blood vessels are, and then you touch the monopolar cautery to the needle and you can close off the vessels. But I think it's in my experience, the best treatment has been to use the anti-VEGFs once the immune reaction is settled down.
Thanks.
Okay, so you can have a Wesley ring, which is which is what we talked about earlier about the immune reaction to the antiviral particles that are left behind in the stroma. And here's the differential diagnosis of ring infiltrates. There's typically 5 or 6 things that can cause it. And don't forget anesthetic abuse. There's occasionally a patient will come in to emerge, and when you've got your back turned, they'll swipe the bottle of anesthetic, or they may be even prescribed it by a family doctor who's unaware of the dangers of chronic anesthetic abuse. And I think I've got some pictures to show. This is typical ring ulcer, most likely. I think this was a patient with acanthamoeba. And here's another. This is a patient of mine that came in with this diffuse ring infiltrate. And here's another one. And if you look carefully here, this is the place where the biopsy was taken. And this was an acanthamoeba patient. And this was a chronic herpes simplex, or it might have been a herpes zoster, I can't recall. And this is another patient that I saw when I was a fellow with actually bilateral Pseudomonas ulcers, and had this beautiful and perfect ring infiltrate, then with these focal infiltrates in the cornea as well, and a hypopyon. And so Pseudomonas can occasionally lead you with that. And the most vexing ones, I think, are the anesthetic abuse patients. Sometimes they're very difficult. It's very difficult to come to the diagnosis because you want to rule out everything else, and you do biopsies and you treat them, tarsorities, and sometimes they come to transplant, and it may take quite a while until you actually can convince the patient, because sometimes they don't want to admit that they're using the anesthetic. We'll move on to indolent ulcers. This is an ulcer that after infection does not heal, and that can be due to drug toxicity, or very commonly if you have an underlying inflammatory reaction. The epithelium does not like to cross across mushy stroma. So you can end up with a chronic defect. There's probably a neurotrophic component to it. And when this occurs, then you have to pull out your whole armamentarium of how to heal a chronic defect. And here's one such defect. Tanya, you were asking earlier about geographic ulcers, and you can see here that this has almost a geometric pattern rather than geographic, with a very smooth edge to it, and it's sort of rolled under. And this is a chronic epithelial defect. Stains, the base stains with fluorescein. And anyone here want to take a stab at what's going on? Anyone? Gisela, you want to tell us about what you think's going on in this patient?
Well, I see like a fluorescent stain and cobalt blue filter, and there seems to be a lot of SPK like diffusely over the cornea, but I don't know.
Yeah,
maybe those little
right.
highlighting points could be a little bit elevated. I'm not 100% sure.
Yeah, it's exactly what you said. It's showing this coarse punctate keratopathy, and this is a patient who'd been on antivirals for 3-4 weeks. So when you're treating a dendrite, you don't need to keep the patient on antivirals for long periods of time. It should be healed within a week, and then I usually start to taper it and get them off of it by 2 weeks. But this is what happens with chronic use of the steroids. And um, once you stop it, you put them on non-preserved tears, it will usually settle down. I think this is also showing toxicity. And if you just look at the light reflex here, how irregular it is, you can see the light staining pattern from punctate keratopathy. And this is also an anesthetic abuse, or sorry, a toxicity from the antivirals. And this patient came in with a huge epithelial defect, and it was nothing more than toxicity from the antivirals. And once we stopped them, put a bandage contact lens on, the situation resolved.
I would like to say, like for the juniors, when it's a very beginning case and you're not 100% sure if it's herpetic or it's toxicity, I would always try to rule out toxicity and like try to just lubricate that cornea properly. And most of the times you'll find out you were worrying about an infection that was never there.
Right. And so you're saying in which circumstance? In the circumstance of herpes simplex, or just
No,
in...
like if you don't know if you have herpes, like if you have a very initial staining in the cornea that you think might become dendritic or something, I think it's also okay to just lubricate and watch them closely, and then
Right.
you will see that most of the times if the patients were developing toxicity, it will get better on its own and it wasn't herpes. You know, like sometimes I think herpes is too many people
Yeah.
think that the diagnosis is herpes, and sometimes it's just toxicity.
Right. Yeah, I think that's a good point, is that, well, you know, herpes and blepharitis you can put on almost any external disease, differential diagnosis, and be correct in that regard. And I agree. I think that, you know, many patients being put on acyclovir, you know, orally, and it may not be necessary. It's like a contact lens problem. If you've got a patient that comes in and they're a contact lens wearer and the eye's a little bit inflamed, you know, often the best first step is just to stop the lens wear and have them come back in a day or so and see how they're doing. So what do you think's going on with this patient here? Michael?
So he seems to have a complete ptosis in his right eye. I'm trying to see if I see some sort of lesion around the periocular region, maybe slightly above the eyebrow area. I'm not really sure. Maybe like right above the eyebrow, I might see a small area that might look like there might be some sort of rash there. But I don't really see anything much than a complete ptosis in the right eye.
Yeah. So he's had a Botox injection, which is, this picture is just in there to remind us that if you've got access to Botox, it's the easiest way to do a tarsorrhaphy. You know, although it takes a few days for it to become active, but it can give a single injection up above here, following the roof of the orbit, and you'll end up with a ptosis. It's nice because you can look at the eye. But in these, you know, in a chronic indolent ulcer, you may not, if you haven't got Botox available to you, the best thing sometimes is just to put the eye to rest, to close it up, and almost always that will get it to heal. So let's just go back to talk about therapy with oral acyclovir. It's not effective in stromal herpes any more than topical steroids and drops, and that was proven by the HEAD study. You can use it for treating epithelial disease, and in kids it might be the treatment of choice, because with kids they squirm around and they tear, and the drops don't get in, and the parents hate it, whereas they can give them oral acyclovir in a liquid form, and they usually do pretty well. And the other is that if the patient's infirm or they don't have someone that can administer the drops for them, oral acyclovir may be the preferred method. And if you've got a patient who's a frequent recurrer, I remember one lady that told me that every time she goes on a trip, she gets a recurrence of her herpes. So in her case, I would just give her a prescription for acyclovir, and she would start it the day before she leaves, and she would stop it when she comes back. And that can keep things under control. And then post-corneal transplant, we keep them on indefinitely on the acyclovir. Now, the studies, like you'll often hear people say, oh, you use it for 2 years and then you stop it. Well, what happens when you stop it? They start to get more frequent recurrences. So the reason 2 years has become ingrained in the literature is because the study only followed patients for 2 years. You know, it doesn't mean that it doesn't work beyond 2 years. It just means that they had to put some limitation on the length of time they followed the patients. And in that case, you know, we came to accept that you only need to use it for 2 years. But in essence, if the patients had a corneal transplant, we keep them on it indefinitely, twice a day, 400 milligrams twice a day, as long as they can tolerate it. Okay, and this is just to review the HEADS 1 study, stromal keratitis, not on steroids trial. Steroids helped, okay, but recruitment was stopped before they had significant values. Stromal keratitis on steroids, acyclovir trial, addition of acyclovir for 10 weeks made no difference. And then iridocyclitis, they found that they had poor recruitment, but a trend was developing. So it was unfortunate that it was a big study. It was done about 30 years ago. And you know, it was unfortunate. They spent a lot of money and didn't come out with much information of significance. The HEADS 2 study was looking at epithelial keratitis with acyclovir, and they found that acyclovir for 21 days was not more effective than trifluorthymidine in preventing stromal keratitis or iritis. And then the acyclovir prevention trial, they did 400 milligrams orally for 1 year, and there was a 50% reduction of recurrence. And but once again, you know, once you stop it, the recurrence rate goes back to what it usually would be. And that's just the reference to the HEADS study. In terms of surgery, we can do it for tectonic reasons, to reestablish the globe. We can do it for optical reasons if the eye has been quiet for a long time, or it can be therapeutic even if there's no chance of improving vision. You may still do a transplant to get rid of diseased tissue. Sometimes what you'll end up doing is just a conjunctival flap, and what that does is it brings blood vessels and brings tenons to cover a chronic indolent ulcer, and you may consider doing that in an eye that has no visual potential or is not a good candidate for a penetrating graft. Superficial lamellar grafts are usually not very successful. DALC, there's been comparative studies to show that the DALC may be equivalent to penetrating keratoplasty. Problem being is that if you don't excise all of the diseased tissue, then you can get a recurrence of the stromal disease in the graft as well. And there's, I wouldn't say it's not an absolute contraindication to do PTK or laser surgery on the eye, but ultraviolet light has been associated with an increased risk of recurrence. But having said that, I do have some patients that I've tried PTK on, and if you keep them on oral acyclovir in the perioperative period, they generally do quite well.
When you say perioperative, do you mean pre and post, or just post?
Well, you can start at the day of surgery before. Was I muted?
Tanya muted herself, and then she muted you, and she's being very controlling of the mute. Thank you, Tanya, for saving me earlier. So just to repeat, Tanya was asking basically about the perioperative dosage. I think that's also a question, and whether you give it only preoperatively or both preoperatively and postoperatively.
I usually will start it on the day of surgery and keep it up until the epithelium is healed, and then for another week or two afterwards.
And dosage?
Dosage would be full dosage,
full dosage?
400 milligrams 5 times a day.
I just wanted to add something small.
Sure.
That the corneal cross-linking is also a very important issue, because we don't have to do must to do refractive surgery, but sometimes we must to do corneal cross-linking, and this is also important to give pre-operative and post-operative treatment with acyclovir.
That's a good point.
I think Mark makes a great point, because there's certainly been studies where patients have not had any history of ocular disease or oral cold sores and still have had an episode of HSV, which is apparently activated by the cross-linking. So I think watching them very closely in the post-operative period and cross-linking is really important.
Yeah, I think that's a good point.
I also wonder about maybe considering an epithelium on technique if you know for sure that they have had HSV keratitis in the past, then maybe epithelium on, despite its potential for being less efficient than epithelium off, maybe it does have a role in these cases.
Yeah, well, if you can do an epithelial on technique, sure. It's not readily available because a lot of those, at least in the US, the technique that they're using is with a proprietary solution that penetrates the epithelium. But yeah, those are all important considerations for sure. Ultraviolet being trauma to the eye and taking off the epithelium itself can be considered a factor, in recurrence of the virus.
And would you differentiate between a LASIK or a PRK in a patient with, maybe this is an advanced question, but would you differentiate between LASIK or a PRK in a patient with
I'd probably go with PRK, because I'd be if you mean just for like an elective PRK.
Yeah, if you had an elective surgery patient, highly motivated, understands the risks, would you prefer LASIK or PRK?
Yeah, my gut feeling is to say PRK, because I don't want to have to create an interface that could later become infiltrated by the virus, or by cut nerve endings that perhaps the virus gets deposited in the lamellar flap. I always wondered about when LASIK first started to become popular. I wondered whether we were going to see like a whole bunch of people 20 years and 30 years down the line that develop rheumatologic disorders, or herpes simplex, because we've created now this artificial plane that remains there for permanently. But we haven't seen like a flood of patients, I'll put it that way. Nonetheless, the short answer is I'd probably go with PRK. I'll just show you some clinical pictures. This is a gentleman that had a corneal graft for herpes and had a chronic epithelial defect that just did not want to heal, despite everything that we threw at him. And in this instance, we used an inferior conjunctival flap, and it'll usually stick down to the areas where the cornea is inflamed, bringing in blood vessels and epithelial cover, and often ends up quieting it down. Here's another example of a conjunctival flap. And the timing of surgery, if you can temporize, I think it's better. We don't like to operate at night because we usually end up with very inexperienced nurses, and I don't think it's good for the patient. I don't think it's good for the surgeon. And so we try and temporize for that reason alone. But the other reason is that if you can settle the eye down prior to taking them to the OR, they're probably going to do better. So, like, for instance, they have a stromal keratitis with a perforation, put some glue and a contact lens on, and in that instance, start systemic steroids for a couple of days before you take them to the OR, as well as some topical steroids. And I think that, and you can put them on oral acyclovir as well. And I think that in that instance, your success rate is going to be better. The studies show about a 75% chance of getting a clear PKP, but you're still about a 15% chance of recurrence. And here's a typical patient with a perforation and a nicely applied glue patch, no bandage contact lens in this photograph. And this is that patient I showed you before with the chronic ring ulcer in a very thin area on the cornea. And what Dr. Kaufman taught us is that if you can excise all of the whitish tissue, that the chance of success is much better. So, you know, if you have to cut through a scar or cut through a white area, sometimes the recurrence rate is higher. And sometimes you get lucky. I remember one patient who'd had 3 transplants before elsewhere, and then she came to see us, and I did a transplant on her, and she's had a couple recurrences, but the graft has stayed clear for at least 10, 15 years. And I don't think it's because I did such a better job than the last surgeon that tried. And I don't know, maybe you're lucky with the histocompatibility, or their virus has gone into a more dormant phase. It's hard to know. And here's a chronic scar with vascularization. This is one that would be useful to treat preoperatively with an injection of anti-VEGF once a month for, say, 3-4 months before taking them to the operating room. What's this one here? It's kind of it's not a great picture, but.
Looks like a perforation.
Positive?
Yeah, side L positive, exactly. So there's the opening in the center, and then you can see the rivulet of aqueous. So this is one that we would, even though it's fairly central, it's one we'd probably attempt to glue with the patch so that we could put them on an elective list rather than do it emergently. And Rebecca, you still with us? Do you want to tell us about this picture?
Yes, so this looks like superiorly there is some elevation or maybe some mucus strand it's hard to say if that's like a elevated infiltrate or
Yeah,
if it's
that's an
mucus.
infiltrate. That's right.
And then below to that looks almost like a delin or an
Is this what you
epithelial
mean?
defect.
Yeah.
Yeah, that area there.
What do you think this is? It's yellowy. It's what you don't want to see on a Friday afternoon in your office.
I mean, it looks like Pseudomonas or something like that, possibly.
It could be, yeah. But this is the lens.
I see.
It's a bit of a, it was a trick question. Sorry about that.
No, it does look different for sure.
So that's what I was saying. That's not what you want to see at 3 o'clock on Friday. So with this one, you'd probably, we'd have to go in fairly soon if we're going to have any success at all of saving this eye. So that would be, you know, a tectonic reason and, or I guess therapeutic. And just to show you some of the sequelae of the herpes simplex with the dendritic pattern, and it shows you the nice little end bulb pattern. And this is the signature that the virus has left on the patient's cornea. That's not showing us too much, so we'll skip it. And here's another recurrence of a dendrite in a post-graft patient. And here is stromal keratitis in a patient that's had a graft. And the importance of this slide is that it's sometimes very difficult to differentiate between the recurrence of the virus and rejection. So we treat them basically the same way with steroids and acyclovir, and we hope that that it clears up, you know, that it's a rejection that responds well to the steroids. Generally, I just treat topically. Some people, once again, will give systemic steroids, but I think you have to be very cautious in the elderly population that we're generally dealing with. And here's a recurrence of, it's possible that it's herpes or it's rejection. Hard to know. Okay. And this was actually from my fellowship as well, a patient with large dendrite after corneal transplant. Okay, I think I'm talked out. Do you have any questions that?
I have a question. Can you hear me?
It's just.
Yeah. So, do you usually treat with topical steroids in a, no, I lost him, right?
Yeah,
no.
I hear you now.
Do you hear me?
Sorry.
Oh, okay, perfect. So
say your question again. Sorry, Adi.
My question is, with those ghost dendrites that you showed us before, do you treat with topical steroids after you finish like a few weeks or never?
No.
So let's say the epithelium is already intact. You think that you've been treated with a cyclovir, either topical or systemic, for a week or so, 10 days. And so you don't add steroids at any stage with those epithelial.
Well, the ghost dendrites, usually you see them, you know, after the episode is completely gone and they're healed up, and you just see that little dendritic-like pattern.
Okay, because here there are few cornea specialists in Israel that do tell you to add steroids, again, topical steroids for those patients. Once the epithelium is
the only reason
closed.
I could see is that if it was right in the middle and it was actually interfering with their vision, you might want to give them some mild steroid to see if it can improve their vision. But generally, I can't think of a single time I've treated them. Treated a ghost dendrite. It's more just the you know, it's an aha moment that the patient comes in, oh yeah, I've had this red eye several times over the past few years, and you look and you say, yep, you had herpes simplex.
Yeah. Okay.
Prof, do you have time for 2 questions from the crowd?
Okay, sure.
The question is for patients with HSV stromal keratitis or endothelitis without epithelial component. I believe we still put them on prophylactic acyclovir dose to prevent any reactivation of epithelial disease. Would you agree with that statement?
I would agree with that. Yeah, you want to put them
Great.
on
And
something.
the second,
Because,
do you want to elaborate on that?
sorry.
Oh,
Yeah.
I said, do you want to elaborate on that? Sorry.
Yeah, no, I agree with that, because if they've there's a good chance that they will develop a dendrite, and so you don't want them to for that to occur while you've just got them on steroids. So the antiviral cover, I think, is there as prophylaxis.
Thank you. The second question would be, would you avoid refractive surgery in patients with previous history of HSV keratitis and some ocular surface disease from a dry eye perspective?
Yes, I think I'm not a big fan of doing PRK in patients with herpes simplex, with a known history of herpes simplex. Having said that, I don't like to be I'm not the type of person that says absolutely no. You know, there are going to be instances where someone comes and say, look, I know I've got herpes simplex, but I really want to be a fireman. So, what do you do then? It's easy. It's very easy to say no. It's just, but it's much harder as a physician to say yes to if it fits in with their professional plans or whatever, and that's their only way of attaining that goal. So.
And we have another question. Is there a difference in efficacy of different oral antivirals, such as acyclovir, Valtrex, and Famvir?
They're all variations of acyclovir, and it's just a matter, from my understanding, is that it's bioavailability, and that's what determines the dosage. Acyclovir is not that well absorbed, so you have to take 400 milligrams 5 times a day to get an antiviral effect, whereas Famvir and what was the other one?
Valtrex.
Yeah, Valtrex, valacyclovir.
Yes.
They're metabolized to acyclovir once they're absorbed. They just have better absorption.
I think Rebecca has very politely raised her hand.
Hi, Rebecca.
Hi. I have a question about culture negative ulcers that we treat with fortifieds. How long does it take for the patient to develop toxicity? Because we've been treating a patient with a culture negative ulcer with Q1 fortifieds for a couple of weeks, and her eyes getting more red and painful. So how would you start to decrease the fortifieds, and would you ever start steroids in this patient?
Yeah, in terms of the antibiotics, you should be able to sterilize a bacterial ulcer within 48 hours. So using the high dose toxic drugs for much longer than a week really shouldn't be necessary. And if it's not starting to show some improvement or stabilization, then you've got to wonder, is my diagnosis correct? And if it's not, then you may go on to doing some more cultures, viral cultures, or biopsy to rule out acanthamoeba infection. But then after 3 weeks, if it's not getting better, then you've got to sort of decide, are you going to do a therapeutic trial with some steroids, or are you going to, just back off on everything and see what happens? So in that case, if you give them a low dose steroids and you follow them and you see them a couple days later, if they're going to get better, they'll probably be a lot better. And if they're going to get worse, they won't be much worse with 3 or 4 times a day. but it would be good to have more diagnostics just to make sure that you're not dealing with fungus. Any underlying conditions that with that patient?
Just contact lens. Where, yeah.
Well, contact lenses, 95% of them are still bacterial. It's still the most common thing. With contact lenses, you start to worry about amoeba, and you want to make sure that you sent the lenses off for culture, send them to the public health lab to see if they can grow amoeba from the solutions or from the lens itself.
One of our juniors had a really great question, which I was going to type out, but I think it's worth addressing just for most of the juniors, that if you have a patient with a non-healing dendrite, when do you try or would you try different antivirals? And I think one of the points that Gisela made before is really pertinent, that you really want to look at what other agents you're pouring onto the eye and remove as much toxicity as you can to start with, and then nourish the eye if you can by using non-preservative tears abundantly. And it's really amazing how much support you can give the cornea in terms of making it, trying to heal. In terms of changing tack with antivirals, I mean, these ulcers do tend to drag on for a little bit, so you probably won't find us switching antivirals that quickly. Prof, I don't know if you have anything to add about like at what point you would consider changing antivirals, because they do tend to drag on.
Well, the problem with the antivirals is that they're all the same, and in the acyclovir family, and the resistance ones, I can think of one patient that had what I thought was a resistant dendrite, and he had a dendritiform ulcer that had been going on for months. He'd been treated with topical trifluorthymidine and with no response, and we got lucky and we treated him with ganciclovir, and we were the heroes for him. But resistance, you're not going to see it in the first couple weeks. You can make that diagnosis probably a couple months later.
Do you tend to make your diagnosis of resistance clinically or on because in Australia, we can only get resistance profiles of HSV after 6 weeks of failed treatment. And we don't actually have access to ganciclovir unless it's through our infectious diseases team. So we sort of have to prove that we have no response for a while before we change tack, which is why it also drags on for so long.
Before you can do what?
Before we can give ganciclovir. We can't just get it compounded off the shelf.
Yeah, we just send them to Haber's Pharmacy, and they make it up for us. So we're pretty fortunate in that regard.
Sorry, I meant that. Do you make the diagnosis of resistance clinically, or do you get microbiological results for that in Canada? I'm just curious.
I don't think there's a way to get sensitivities for viruses, as far as I'm aware. So I think it would be a clinical diagnosis.
We can get resistance profiles in Australia, but it just takes forever, like 6-8 weeks. Yeah. So I was just wondering, like, how that diagnosis is made in Canada.
Yeah, I wasn't aware that you could get sensitivity testing for viruses, but yeah, I think it would be clinically as just a patient not getting better on the acyclovir and still a strong suspicion that it's active viral proliferation.
Thanks.
All right, any other questions? Okay, so we'll continue next week with herpes zoster. And I wanted to thank everyone for taking the time out of their busy schedules. It's nice that we've had this chance to focus on educational activities. So we'll see you next week.
Thank you very much.
Thank you so much.